Good afternoon. Welcome to another edition of McMaster Perspective. We have distinct pleasure to have with us Professor Isa Gopole, who is the immediate past president of ACP. We have a pleasure to host Professor Gopole on Medical Education Forum, which is part of McMaster International Conference in Internal Medicine. Professor Gopole, I had a disadvantage of not being able to listen to Medical Education Forum. You were presenting there on something called
Yes, I did.
ACE. Would you be so kind to summarize for me and for the audience what was your presentation about?
Yeah, my presentation was on the ACE curriculum, which we implemented at the University of Kansas Medical Center. And the session was a medical education innovation session. And I actually started my presentation by describing that it was not actually an innovation, but an implementation of something that McMaster has been doing for several decades. The active learning, competence-driven and competency-based and excellence-driven curriculum that we designed was very much similar to the type of curriculum that was developed in McMaster, the so-called McMaster system. So I first of all apologize to anybody from McMaster for plagiarizing their ideas.
You're welcome.
But in a nutshell, the ACE curriculum that we developed changed our curriculum from the traditional 2-year scientific and then 2-year clinical type of program to one where the students became clinicians right from day one. In fact, the second lecture in the entire medical school is a physical examination lecture that I give, which immediately follows a history taking lecture that one of my colleagues gives. So the first lecture is on history taking. The second lecture is physical exam.
So no histology or anatomy as the first 2 lectures?
No. All of that comes in, but that is peppered into the clinical and problem-focused curriculum that we designed. So yes, there is anatomy and histology, but it is all peppered in. But the focus is on the student to develop their professional identity as a physician as soon as they walk into that door the first time when they come into medical school.
Well, you mentioned this professional identity, and you mentioned another phrase here, which was patient-physician trust. Is that part of it as well?
That is part of it. The first part of the professional identity is very crucial to the development of what I can refer to as a street person, the regular graduate out of college, to turn into the persona and the character that we want a physician to become. And that's what I refer to as a professional identity formation. In the process of turning this person into a physician, they need to be trustworthy. The concept of trust, why should the patient trust you, is another thing that we have been working on. And we have actually had a couple of publications with some colleagues out of Boston University on some work that we did on the development of the learner as a physician during a clinical exercise and the concept of earning a patient's trust as they go through that exercise.
Could you give us some practical example which could be of value to all of us?
Oh, absolutely. For example, when a student, let's say, goes into a patient's room and asks the patient, "Can I examine you?" There is already an assumed amount of trust. The patient will be trusting that you are an honest, well-trained individual, and that he or she can be comfortable in your skills and in representing them when you come to talk to your superiors. So that is really the beginning of that element of trust. But it goes beyond that. In medical training, we now talk about entrustable professional activities. What is an entrustable professional activity? It is an activity that we can trust the learner to do on their own without supervision. Now, for you to be able to do that on a patient without supervision, the patient also needs to trust you. So there are 2 layers of trust here. Trust between the patient and the learner, but also the trust between the learner and their supervisor. So trust is a really important thing in this entire system for us to be able to train the learners, but also for the learners to care for patients.
Well, you obviously there is a different threshold of trust, both from the supervisor, learner, and the patient. And sometimes this trust may be. Is it easy to break such trust? What do you think?
Oh, the trust is very easy to break. And unfortunately, we are seeing some of that trust being broken out in the public arena, where the public is trusting physicians and scientists less and less. For want of a better phrase, the anti-science movement that we're seeing in the United States, in Canada, other parts of the world, is part of a breach of this trust. It is very easy for that trust to be broken. But at the bedside, the trust can be broken even just by a single sentence, a single word, a single gesture. You may come into the patient's bedside and you're standing and you're looming and your hands are in your pocket, and the patient looks at you and says, "Can I trust this person to take care of me? They don't look like they care." So it's very easy to lose that trust, both at the bedside but also on a much larger scale globally.
I was talking earlier to a group of people from Society of Bedside Medicine, and it looks that our skills in verbal and non-verbal communication with the patient may be as important as technical skills of operating EKG machine or blood gases syringe or whatnot.
Yes.
So this is really what you described here is this active excellence and competency training, which takes over the medical education. You were awarded number of distinctions as an educator.
Yes.
It was quite impressive when I looked through your CV, and it's striking. What made you a educator appreciated by learners? Because this is the most important, I think, reward.
Well, I have been an educator for a very long time, much longer than you can imagine. And I will tell you a story. Straight out of high school, I actually became a teacher. I became, we were referred to as an untrained teacher, but I taught high school. Straight out of high school myself. So I was basically teaching my age mates. And I learned how to relate to learners in that personal sense, where I am teaching and I have to be the teacher, but I also have to relate to you as an individual. And I think it helped me later on when I became now a faculty member, that I continued to maintain the sense of relatability while also being very demanding of the teacher, of my learners. And that kind of rolled then into my starting to win awards. I then became a leader in education. I became a clerkship director, an assistant dean for student affairs, and eventually an associate vice chancellor for student affairs. But throughout that time, I was teaching. I was at the bedside with students, and my teaching style, which was firm but fair and relatable, I think is what led to those teaching awards.
Well, it's quite interesting. I would say that all the titles or dean or program director are not worth as much as the award by clerks or residents to name you as a best educator. I can only relay on some level to you. If somebody asks me what's my profession, I'm a critical care physician, but I'd rather say I'm a teacher, an educator, because that's most important, frankly, aspect of my role.
In many ways, that's probably what I am. I do a lot more teaching than actual patient care. The students and the residents take care of the patients, and I do a lot more of my work
and
teaching.
That's at this stage probably more important.
Yes.
So thank you very much for this exploration of educational aspect of your story. Professor Opola, I have to say that when I first met you, from the perspective of a person raised in Europe and practicing in North America, I find fascinating the role from which ends up as the president of American College of Physicians.
Yes.
But starting in Nairobi, Kenya.
Yes.
Tell us about this work. Tell us the story. How did you accomplish that?
Well, I did not accomplish it. It happened.
It happened by itself. Great.
But I went to the University of Nairobi. I got my medical degree at the University of Nairobi. I was one of two students to have, at the same time as going through medical school, been selected for an intercalated program, Bachelor of Science program in anatomy. It's very research focused, and it was led by a very strong individual. Professor Kimani was our teacher and mentor. And with him, I also got a very strong foundation in educational discipline and and training in science. And during, I think, my third or fourth year in medicine, I met Dr. James Fallon, who again became my mentor. And eventually I came to work in Dr. Fallon's lab at the University of California in Irvine. I got my doctoral degree there and then moved to Kansas, where I became a medical resident and joined the faculty at the University of Kansas. And so working at the University of Kansas is when I joined the American College of Physicians as a resident, and I've been a member ever since, attended every single meeting. But during that period at the University of Kansas, and the work that I was doing led me into leadership positions within the Kansas chapter of the American College of Physicians. I sat on the chapter council and eventually became the governor of the Kansas chapter of the American College of Physicians. At the end of that period, my peers elected me to the Board of Regents of the American College of Physicians. And then subsequently, my peers again elected me to president of the American College of Physicians. So it was really a recognition by my peers that got me to that position. But I think some of the foundational work with some of my early mentors was a significant contribution.
It's obviously you made, in a traditional sense, you made a career out of your medical profession on a quite a large scale. And two elements which struck me is, one, you have, by the sound of it, fantastic mentors.
Yes.
You probably have to choose them. I mean, those things don't happen just because they probably recognize something in you, but you also recognized something in them.
Yes,
and
that
then,
is true.
And then again, it doesn't happen by itself. You had to use the opportunities which were given to you.
Yes.
If you were giving an advice to today's young people who are, call it ambitious, or want to succeed beyond the regular, what would you tell them?
Well, of course, finding and having a mentor is very, very important. But even more important is be engaged, be enthusiastic, and be there. If you're not at the table, you're on the menu. So when I'm talking about being there is mentally, physically, socially, and otherwise. You have to be present. So work with your mentor, but be available. Volunteer, stand out one way or another. People will notice when you're hardworking and you're enthusiastic about the things you do, opportunities will come your way. If you're not there, if you're reluctant, if you're not, quote, present, opportunities will not come your way.
Well, it's interesting what you said. If you're not at the table, you're at the menu. That's quite something.
There you go.
So let's thank you for this segment of motivational speech, so to speak.
Well, thank you.
And in the last segment, I would like to move towards your clinical work.
Yes.
I understand that you work in hospital. I don't know whether I can call it hospitalist or not.
Yes,
but you are
hospitalist.
also working in assessment and preparation of people for surgeries. I wonder if we could talk a little bit about risk assessment, risk stratification, and preparation. What could be done when frail or elderly or person with multimorbidity is faced with elective or semi-elective procedures?
Yeah, and that's an important part of our work in internal medicine in general, but also with patients in the hospital medicine setting. Patients are much more elderly now and much more frail and often have multiple comorbidities. And it is daunting, for example, for an orthopedic surgeon in the middle of winter to have to replace a knee on a patient who has stage 3 chronic kidney disease, uncontrolled diabetes, hypertension, MI, and so on. You know, our typical, I want to call it nowadays, typical internal medicine patient. And a lot of the time they approach us and say, well, can you clear this patient for surgery? Are they ready for surgery? And the most important takeaway that I would want any listener and any viewer for this session to take is that it is not about clearance. We are not air traffic controllers, or shall we say operative room traffic controllers. Our job is to evaluate the patient, assess the risks that exist with that patient at that time or that would exist at the time of surgery, and give opinions as to how to mitigate that risk. The decision to do the surgery remains a decision between the surgeon and the patient. But we assess the patient, we evaluate the risk, and we give suggestions and ideas on how to mitigate the risk.
By mitigate, we mean decrease rather than eliminate.
Decrease rather than eliminate, because sometimes the risks cannot be eliminated, and sometimes the surgery cannot be avoided. But it is a much better conversation when everybody understands the risk and understands that attempts have been made to mitigate the risk, instead of just going to take the surgery and then saying, oops, I didn't mean for that to happen. So once the patient has gone to the operating room and come back, then we also have to continue the perioperative care of the patient and continued risk mitigation, because some of these risks continue. A patient with stage 1 chronic kidney disease may suffer a hypotensive episode in the operating room that may produce an acute kidney injury and may need management beyond that. A patient may develop encephalopathy due to anesthesia and other medications and may need to be managed beyond that. Patients can suffer myocardial ischemia during surgery and may be at risk for arrhythmia or other cardiac events around that. So the risk mitigation continues after the surgery, and that is really our role as a hospital internal medicine physicians, to care for these patients through that period and let the surgeons do what they do best, which is the technical aspect.
I just wonder to what degree it fits to my previous interview when I was talking to people from bedside medicine, from Society of Bedside Medicine, and also we were talking about communication. Frequently, we are both internists, and you come to the patient who's suffering the complication, and they had, in my opinion, huge surgery, say pneumonectomy, and the patient says, "Oh, how come those things are happening to me? My surgeon told me that everything will be okay and I will be home in 3 days, and suddenly all those things are happening." I think it's a matter also of honest discussion with the patients.
And exactly why that initial risk stratification process is important, because you can now at least fairly accurately tell the patient what to anticipate. Unfortunately, sometimes the surgeons are a little too optimistic. It'll be quick. We're going to take care of this. It'll be 2-3 days. But there's a lot of underlying things that might delay that process. Risk for developing thrombi and so on. And so risk stratification helps you, the hospital medicine physician, and the surgeon also to have that conversation with the patient saying, hey, the surgery itself is pretty simple, but your diabetes might give us a little bit of difficulty in controlling, or you may have trouble getting up and walking because you have very severe rheumatoid arthritis. So that might delay your recovery from this. And that communication is very, very important. So the patient goes in understanding what's going on, and the surgeon also goes in understanding what is going on. Again, the best patient is the well-informed patient.
And it ties into this patient's physician trust, which frequently in this situation is something unexpected happens from the perspective of the patient. This trust may be broken.
Yes, the trust may be broken if the patient perceives that they were sold one thing and received another. But this the bond of trust is actually strengthened when something that may go wrong, but it was something that was explained and in some sense anticipated. They are much more likely to accept it and cooperate and
mitigate
understand.
it. Professor Opola, specific question. These days, 20% of my patients who goes through surgery end up with elevated troponins.
Yes.
I'm not sure whether you have the same problem.
We see elevated troponins a lot.
What do you do with it?
Good question. You're taking me back a few years to a study that we did with Dr. P.J. Devereaux from
McMaster.
McMaster, yes. And we were looking at the concept of MINS, myocardial injury after non-cardiac surgery. And we looked at these patients. It was a very difficult clinical trial to perform. I don't think I recruited more than 1 or 2 patients really for that trial. But it is a significant problem that we are dealing with. And we really, at this point, do not have a good answer to what needs to be done. I think at the time we were looking at putting these patients on anticoagulation, but we don't have a good answer as to what to do for these patients. I think the standard treatment right now for these patients is to still evaluate them a little bit further to see the extent, if any, of myocardial injury, and then treat them as a patient who has suffered a cardiac event like you would any other patient. I don't think we have anything special for them, but it is one of those things I would say that, as the saying goes, be careful what you look for because you might get it. And we look for elevated troponin, and we sometimes
you
get
find
it.
it, and you better know what to do with it. But one answer probably is don't ignore it.
Don't ignore it, because I think there is good evidence that these patients over a long period of time, even 30, 60, 90 days, even 6 months post-operatively, are at higher risk for cardiac
double
adverse.
or triple in comparison to that.
Yes.
Professor Opola, thank you very much. Thank you for your work in community with the learners and with the ACP. Thank you.
Thank you very much.
Thank you very much.
Yes,
okay.
thank you.
Goodbye.